Welcome to the Deep Dive, the show where we take a monumental collection of expert sources, articles, research papers, clinical guidelines, and distill them into the essential, sometimes surprising, nuggets of knowledge you need to be truly well-informed.
Today, we are undertaking a really high-stakes deep dive into pharmacological management. We're focused particularly on psychiatric and neurological medications, antidepressants, stimulants, anxiolytics.
Right.
But the principles we're going to uncover, they really apply across all of medicine. The mission is to navigate the immense complexity of modern drug safety, efficacy debates, and the truly invisible world of drug interactions.
And our sources all confirm that successful medication management today is an intensely personalized exercise. It's not one size fits all.
No, absolutely not. It requires balancing a very serious clinical need against often nuanced and critically dose-dependent risks.
So we're not just looking at a pill's primary function. We're investigating its systemic ripple effects, how it impacts the heart, how the liver processes it, and, how one substance can completely sabotage another.
Exactly. We aim to extract the data points that are absolutely critical for decision-making. We'll be focusing on things like the adolescent antidepressant paradox, where, safety warnings led to some really serious unintended public health consequences.
And we'll also get into the nitty-gritty, like the specific dose limits you need to know to prevent serious cardiovascular events.
Yes, and we will absolutely spend time in what I call the hidden battlefield of the liver, where a simple lifestyle factor, like smoking, can render a life-saving medication practically useless.
Okay, let's unpack this, starting with section 1. The adolescent antidepressant paradox. This is, one of the most clinically sensitive areas in pharmacology.
It really is. And our sources immediately confirm the urgency. Depressive disorders are the leading cause of disability worldwide in people aged 15 to 44.
And when it comes to adolescence, depression is, tragically, a major predictor of future suicidal behavior.
That's the critical context. That need for an effective intervention runs headlong into the major safety issue that was identified back in the early 2000s.
The turning point.
The crucial regulatory turning point came in 2004. The FDA reviewed a whole slate of controlled pediatric antidepressant trials. And when they aggregated the data, it suggested an increased risk of suicidality.
And just to be clear, suicidality means what exactly?
It's a specific term. It means both suicidal thoughts and behaviors. And this risk was clearly associated with the use of these drugs in youth.
That led, of course, to the mandate for the infamous black box warning. It's the highest safety warning the FDA requires, right?
The highest.
So what did it specifically force clinicians and caregivers to do? It must have been a highly structured set of instructions given the gravity of the finding.
It was, and it fundamentally changed pediatric care. The black box warning, issued in 2004 and updated in 2007, it clearly stated that antidepressants increase the risk of suicidal thinking and behavior in children and adolescents being treated for major depressive disorder and other psychiatric disorders.
Okay, so it states the risk, but what are the action items?
It imposed 3 core responsibilities. First, clinicians must consciously balance this acknowledged risk against the absolute clinical need because, the depression itself is a life threat.
Of course.
Second, patients have to be closely observed, really closely, for any signs of agitation, irritability, clinical worsening, or any unusual behavioral changes. This is especially true early in treatment or after a dose change.
And the third point, that's about the parents, the caregivers.
Yes, and it's critical. Third, caregivers must be thoroughly advised on these monitoring requirements and, really encouraged to communicate frequently with the prescriber. Any little change, they need to report it.
So the FDA didn't forbid the use, they mandated hypervigilance. And the foundational study that really drove this whole understanding was the TAD study, right?
That's the one. The Treatment for Adolescents with Depression study. It ran from 2000 to 2003, and it was pivotal.
So how did TAS compare the options that were available to these young patients?
TADS was a really smart comparison. It looked at depressed adolescents aged 12 to 17, and it compared 4 parallel treatment arms. You had cognitive behavioral therapy, or CBT, alone.
Okay.
Then you had the SSRI, fluoxetine, Prozac alone. Then a combination of both CBT and fluoxetine. And, of course, a placebo group.
A 4-way race. And what did the safety data from TADS immediately reveal about the risk of these suicidal events?
Well, when you focus just on the medication, the data was pretty stark. Fluoxetine alone was associated with a higher rate of what they called harm-related events.
How much higher?
Adolescents treated only with the medication were statistically twice as likely to experience a suicidal event compared to those getting the combination therapy or just CBT alone.
Twice as likely. That is a huge signal. It absolutely justifies that regulatory caution.
It does. It was a clear signal that the pharmacological intervention, if you use it in isolation, carried substantial risk in this vulnerable population.
But, and this is the crucial part, we also have to remember the point you made earlier, depression itself is a life-threatening disease. So, was fluoxetine actually effective at treating it?
It was profoundly effective, especially compared to placebo. Fluoxetine alone resulted in a reduction of depressive symptoms in about 61% of the youth treated,
And the placebo group.
only 35%. So the primary conclusion wasn't that fluoxetine should be avoided. It was that the combination fluoxetine plus intensive CBT was the optimal path.
So the therapy acts as a sort of protective buffer.
Exactly. This dual approach improved the outcomes while also significantly reducing the suicidal risks that they found with the drug when it was used alone.
And it's important to stress, I think, that this is why fluoxetine holds a unique place. It's not just any SSRI in this context.
No, it isn't. Of all the SSRIs studied in youth, it demonstrated the largest and most consistent difference between the active drug and the placebo response.
Which is why it's the only one specifically approved by the FDA for youth depression.
Exactly. It has the proven efficacy, but that risk profile demands very specialized management. And here's where the story gets more complicated, because this is what leads us into the paradox.
Right. We have this robust data supporting the black box warning. But what happened on a population level after the warnings were issued and, the media coverage was intense, did the overall rate of youth suicide go down?
That's the billion-dollar question. And you're highlighting the unintended consequences. Some earlier population-level studies found an inverse relationship between youth suicide rates and the use of antidepressants between 1990 and 2000.
An inverse relationship. So as prescriptions went up, suicides went down.
Essentially, yes. As SSRI prescribing increased, the overall suicide rates actually decreased, especially in these difficult-to-treat, high-risk groups like older adolescent males who often go underserved.
So you had a decade of data suggesting that broader access to these treatments correlated with fewer deaths.
Right. And then the FDA warning comes out, and it correctly highlights an individual risk that was revealed in these controlled trials. The result: a public health crisis created by fear and withdrawal of treatment.
This is the crux of the issue. A Harvard Medical School study led by Luffy and colleagues in 2014, they investigated this impact specifically. What was the fallout from all that media attention after the FDA mandate?
The effect on prescribing habits was immediate and, frankly, dramatic. Antidepressant use plummeted. We're talking a 31% reduction in adolescents and a 24% reduction in young adults.
Wow. And what did that lead to?
This population-level reduction in treatment was statistically associated with small but significant increases in suicide attempts among the age groups most affected.
That is a staggering finding. The regulatory measure that was designed to protect young people from the risk of the drug appears to have increased the risk from the underlying disease untreated depression, which itself leads to suicidal behavior.
It's the paradox.
So how do researchers and clinicians reconcile that? I mean, it's an impossible scenario.
They cautioned that while the regulatory warning was scientifically justified by the trial data, the subsequent reduction in prescribing left a huge number of depressed young people without appropriate, effective treatment.
So the conclusion isn't that the warning was wrong.
No, not at all. The conclusion is that the public response, this massive avoidance of treatment, was detrimental. It just underscores that proper management relies on close supervision and monitoring of the patient, which the warning mandates, rather than wholesale avoidance of an effective drug.
So the professional bodies, like the American Academy of Child and Adolescent Psychiatry, they continue to support using fluoxetine, but only within that framework of intensive monitoring.
That's the standard of care.
Before we close this section, you mentioned one major caveat about the TEDS trial data, something that was excluded.
Yes, and it's a critical limitation. The trials that were used to mandate the black box warning, they excluded youth who presented with severe, immediate suicidality.
Why?
They were just considered too high risk for the controlled environment of a research study.
So what does that mean for the data we have?
It means the existing safety data is critically lacking for the very population that needs the most intensive intervention. We actually know less about the risk-benefit ratio for the highest risk group than we do for the general population of depressed adolescents.
That puts a permanent asterisk on the entire risk calculation. It forces clinicians to operate, partially in the dark for their most vulnerable patients. Let's shift our focus now from that difficult risk-benefit analysis in adolescents to a more fundamental clinical choice for adults. The complex debate between selective serotonin reuptake inhibitors, SSRIs, and serotonin norepinephrine reuptake inhibitors, or SNRIs.
Yes, this choice is absolutely central to first-line care for depression, and it relies on understanding not just outcomes, but some pretty subtle mechanical differences between the drug classes.
Okay, let's start with the basics. SSRIs like fluoxetine or sertraline, what are they doing?
SSRIs are highly selective. Their main job is to block the reuptake of the serotonin transporter. This increases how much serotonin is available in the synaptic cleft, and this provides a wide therapeutic index and generally results in a better side effect profile than the older drugs.
And when you introduce norepinephrine into the equation with the SNRIs, drugs like venlafaxine or duloxetine, how does that mechanism change? And why is that significant for, how well people tolerate them?
Well, SNRIs, as the name implies, inhibit the reuptake of both serotonin and norepinephrine. The key to their improved tolerability, especially compared to historical predecessors like the tricyclic antidepressants, the TCA,
Right, the old ones.
is that they lack any clinically significant affinity for adrenergic, cholinergic, or histaminergic receptors. TCAs had massive affinity for those receptors, and that's what led to severe side effects like cardiotoxicity, dry mouth, confusion, just a whole host of problems.
So the SNRIs give you that dual action boost from norepinephrine without that really dangerous side effect burden.
You've got it. That's the goal.
So we get this dual neurotransmitter coverage, which theoretically could lead to stronger or broader efficacy while maintaining a relatively safe side effect profile similar to the SSRIs. Now, let's address the clinical controversy. Which group is actually more effective? The source material suggests it's a bit of a mixed bag.
It is very mixed, which is why this debate persists. Early on, and in some very specific studies, there was a distinct advantage for the SNRIs.
Like in what situations?
For instance, in outpatients with major depression who also had comorbid anxiety, double-blind trials demonstrated that venlafaxine XR often yielded higher response rates than fluoxetine.
How much higher?
In one trial, the response rates were as high as 75% for venlafaxine compared to about 51% for fluoxetine in patients with that anxiety comorbidity.
That's a massive margin. It really suggests that when depression is complicated by generalized anxiety, that dual action might be essential.
It's a strong indicator.
Does this superiority hold up in the most severe cases of depression?
Yes, the data supports that.
Mm.
In severe treatment-resistant cases, studies comparing venlafaxine to paroxetine, another SSRI, found venlafaxine to be more effective. Similarly, duloxetine was shown to be superior to paroxetine in some comparative trials.
So a consensus started to form around this.
A general consensus, yes. The idea became that if you have high severity, treatment resistance, or specific pain comorbidity, the norepinephrine component likely provides that necessary extra clinical boost.
You mentioned pain. That's a big one.
The huge one. SNRIs are widely reported to have anti-pain effectiveness, which makes them the preferred choice when chronic pain is a major feature of the patient's presentation.
But the SSRI group has a very strong contender that complicates this whole narrative. Citalopram. Where does that drug fit into the efficacy comparison?
Citalopram.
There.
It's often the preferred SSRI for a lot of clinicians, and for good reason. It has very high selectivity and excellent tolerability. And when you look at pooled analyses comparing it directly to leading SNRIs, including venlafaxine XR, the overall efficacy rates were found to be comparable.
Comparable. So it sort of closes that gap we were just talking about.
It does. But citalopram also offered two significant advantages that can swing the clinical choice in its favor for many, many patients.
Okay, so what are those key advantages that might make you choose it over the potential efficacy boost of an SNRI?
First, patients on citalopram achieve sustained remission significantly faster. This rapid response can be absolutely critical in reducing the overall burden and risk of depression.
And the second advantage?
Second, and this is perhaps more important for long-term adherence, citalopram demonstrated better overall tolerability.
Can you specify what that better tolerability looks like? Is it a difference in how many people quit the drug or the type of side effects they experience?
It's both, really. SSRIs are generally better tolerated overall, and that leads to higher treatment discontinuation rates for the SNRIs.
People just stop taking them.
Right. Specifically, patients on citalopram reported significantly fewer gastrointestinal side effects, things like nausea and constipation, and fewer anticholinergic effects like sweating. And crucially, they reported fewer and milder withdrawal symptoms when they stopped the medication compared to venlafaxine.
Which is known for that, right? The withdrawal.
Yes, venlafaxine has a notoriously short half-life, which can lead to a very rapid, uncomfortable withdrawal if you miss even a single dose.
So the individualized choice here requires a pretty careful trade-off. If a patient is stable, highly motivated, and dealing with very severe symptoms or pain, maybe an SNRI like venlafaxine is the best option.
That could be the case.
But if they prioritize quick relief, minimal side effects, and smooth treatment transitions, citalopram often wins, despite maybe slightly lower efficacy for the absolute most severe cases.
That's the exact clinical synthesis. There is no universal superior drug group. It's about matching the drug to the patient. SNRIs for severity, pain, or comorbid anxiety. Highly selective SSRIs like acetaminophen for balancing efficacy with excellent tolerability and faster remission.
What about cost? Is there a big difference?
Cost is generally comparable these days, with generics available. But in one notable analysis from Sweden, citalopram was actually deemed the most cost-effective option, specifically because of its superior tolerability profile and lower rates of non-adherence. People just stick with it longer.
Let's talk a bit more about those side effect profiles, particularly the sexual dysfunction component, which is a major factor in patient adherence.
It's an enormous issue. It can impact up to 80% of patients receiving depression therapy. It's huge.
And it's not the same for every drug, is it?
No. While it is often discussed generically, the data shows that the drugs with the highest degree of serotonin reuptake blockade exhibit the highest rates of sexual dysfunction.
So the ones that are best at being SSRIs are also the worst for this side effect?
That's a good way to put it. This means the highly selective serotonin agents, citalopram, fluoxetine, paroxetine, sertraline, and yes, venlafaxine, because of its serotonin action, exhibit the highest rates of overall sexual dysfunction. It's an unavoidable, difficult conversation clinicians must have at the very start of treatment.
Now we need to transition to what are arguably the most critical and potentially life-threatening risks. The cardiovascular and systemic organ risks that prescribers absolutely must monitor, often requiring, specialized lab work or diagnostics.
Right, we have to begin with the heart, and specifically the dose-dependent risk of QTc prolongation.
QTc prolongation, can you break that down for us?
Sure, it's a measurement on an ECG, an electrocardiogram. It's the time it takes for the heart's ventricles to electrically contract and then completely recover or repolarize. If this interval is too long, the repolarization phase becomes unstable.
And what is the serious, life-threatening consequence of that instability?
The risk is a condition called Torsades de Pointes, or TDP. It's a very specific, serious ventricular arrhythmia that can rapidly degenerate into ventricular fibrillation and, well, sudden cardiac death.
And you said this is dose-dependent.
Highly dose-dependent.
Right.
And the clinical red flags are very clear. The risk increases significantly if the QTc interval prolongs by more than 20 milliseconds from the person's baseline, or if the QTc exceeds 500 milliseconds in total duration.
So which psychotropics, including the common ones we've just discussed, are categorized as high risk by the FDA for this QTc prolongation?
Unfortunately, two of the most popular and generally well-tolerated SSRIs fall into this high-risk category, citalopram and its active enantiomer, citalopram.
Really? The ones we just said were so well tolerated?
Yes. Citalopram shows a mean QTc change of about 10.58 milliseconds, and acetaminophen shows about 7.27 milliseconds. Now, those seem like small changes, but they mandated regulatory intervention because the consequence of TDP is so serious.
That intervention resulted in firm, non-negotiable dose caps, correct?
Absolutely correct. The FDA stepped in, recommending a hard maximum dose of 40 milligrams per day for citalopram for most adults. And crucially, that maximum dose is immediately cut in half to 20 milligrams per day for any patient over the age of 60.
Why the age cutoff?
It's due to the age-related decline in drug clearance and just an increased general cardiac vulnerability.
So how do clinicians practically manage this risk? I mean, given the seriousness of TDP, should every single patient on citalopram be getting an ECG?
For a standard dose, low-risk patient, typically no. But the guidance is very clear. A baseline ECG is necessary for anyone starting a high-risk agent who has existing risk factors.
What are those risk factors?
The big ones are being elderly, female sex, having existing cardiac disease, especially history of a heart attack or congestive heart failure, and most importantly, low levels of key electrolytes like potassium or magnesium.
So you need a blood test too?
Yes. And furthermore, anyone on 2 or more QTc prolonging agents absolutely requires an ECG. You have to monitor for that additive effect.
You mentioned other psychotropics carry even higher risks. Which ones should prompt the most concern?
Several of the older and even some newer antipsychotics pose a far greater risk. Chlorpromazine and thioridazine, for instance, are associated with the highest mean changes, sometimes between 33 and 41 milliseconds. That's a massive increase.
Wow.
And even common agents like haloperidol and pimozide carry a high risk, with pimozide showing a mean change of 19 milliseconds. For these agents, the monitoring has to be extremely vigilant, often involving serial ECGs to prevent a fatal event.
Okay, let's pivot to the second major cardiovascular risk, this one associated with our SNRI class, hypertension. You mentioned this is directly linked to that norepinephrine mechanism.
That's right. The inhibition of norepinephrine reuptake creates a systemic rise in sympathetic tone, which results in a dose-dependent increase in blood pressure, predominantly diastolic blood pressure.
And is there one SNRI that's worse than the others for this?
Yes. Of all the SNRIs, venlafaxine is the most notorious agent for inducing sustained hypertension.
At what point does the dose become too risky? If a patient is on, say, 75 milligrams a day, should they be worried about their blood pressure skyrocketing?
Not typically. The risk is highly dose-dependent, and it really only becomes statistically and clinically significant at dosages above 300 milligrams per day.
Okay, that's a pretty high dose.
It is. At that high dosage, the incidence of sustained elevation, meaning an increase of 10 millimillic or more from baseline, is reported to be around 13%. This requires proactive management.
And what does that proactive management look like?
It's standard management protocol. It requires rigorous blood pressure monitoring at baseline within the first month of starting or changing the dose and at every single subsequent visit.
And if you see a problem?
If the patient's blood pressure is consistently elevated, or if it increases by more than 10 millimilli from their baseline across 3 consecutive visits, the clinician has to intervene. That could mean starting an antihypertensive agent, reducing the venlafaxine dose, or switching the patient to a non-SNRI agent altogether. You just can't let the drug sustain clinically significant hypertension.
We absolutely must also address the ubiquitous ADHD medications, both the stimulants and non-stimulants, which carry a serious, though rare, cardiac warning.
Yes. Stimulants like methylphenidate and amphetamine salts and the non-stimulant atomoxetine, they all increase sympathetic outflow, which raises blood pressure and heart rate.
By how much?
Methylphenidate typically raises average blood pressure by 2 to 4 mmHg and heart rate by 3 to 6 bpm. Atomoxetine in some studies had an incidence of heart rate increase as high as 23%. These are small changes, but they can stress an already compromised system.
If the changes are that small, is the risk of a catastrophic event, like a sudden cardiac death, substantial for a generally healthy patient?
No, thankfully, the incidence of sudden cardiac death or serious cardiovascular events associated with these drugs is extremely rare. We're talking less than 0.01%.
But the risk isn't zero.
The risk is not zero, and it is overwhelmingly concentrated in patients who already have pre-existing and often undiagnosed structural cardiac abnormalities. This critical caveat is why amphetamine mixed salts carry a black box warning regarding abuse potential and serious cardiovascular events.
So the general guidance is strong screening first, rather than automatic avoidance for all. What specific cardiac screening is required before you start a stimulant?
Thorough screening is mandatory. It involves a baseline review of the patient's and, critically, their family's cardiac history. You're looking for sudden, unexplained deaths or early cardiac events.
And then monitoring.
Blood pressure and heart rate must be measured at every visit. And the drug should generally be avoided in patients with known structural cardiac abnormalities, known cardiomyopathy, or pre-existing heart rhythm abnormalities. If any concern arises during that screening, like unexplained fainting or palpitations, a cardiology consult and an EKG are warranted before you continue treatment.
That covers the macroscopic risks to the heart. Now we need to dive into the truly microscopic yet profoundly important mechanics of drug processing, this vast network of enzymes in the liver known as the CYP450 system. This is where compliance and efficacy can completely fail because of external factors.
This system is the body's highly efficient, customized detoxification and processing plant. It contains dozens of enzymes, but 3 are particularly critical for psychotropics: CYP1A2, 2D6, and 3A4. And these enzymes can be profoundly affected by other substances,
Leading to one of 2 critical scenarios.
Right. Enzyme induction, which is speeding up metabolism, or enzyme inhibition, which is slowing it down.
Let's start with a major lifestyle factor that causes enzyme induction: smoking. How does the simple act of inhaling tobacco smoke derail a medication's effectiveness?
This is so important. The tobacco smoke doesn't interact with the drug itself, it interacts with the liver. Tobacco smoke contains polycyclic aromatic hydrocarbons, or PAH. These are just products of combustion.
And these PAH, what do?
They act as potent inducers. They essentially hit the accelerate pedal on specific drug-metabolizing enzymes, primarily CYP1A2 and 1A1.
So the liver shredder is just working overtime. What's the disastrous result for the medication the patient is taking?
The drug is metabolized and cleared from the bloodstream far faster than intended. This results in significantly decreased plasma levels and therefore reduced clinical effectiveness. This effect is clinically significant if the person smokes more than 10 cigarettes per day.
And the patient will seem like they're not responding to treatment?
Exactly. The patient will often seem treatment-resistant or just fail to respond, when in reality, they just aren't retaining enough of the drug in their system.
Give us some specific numbers, because the data here is just shocking. How dramatic is this reduction in levels for commonly prescribed psychiatric medications?
The effects are profound, especially for drugs that are metabolized by CYP1A2. Clozapine, a crucial antipsychotic, can see its plasma levels decrease by up to 50%.
50%, half the drug, gone.
And haloperidol, a high-potency antipsychotic, can drop by a staggering 70%. We also see substantial decreases for common agents like Duloxetine, a 38% decrease, Fluoxetine, a 39% decrease, mirtazapine up to a 41% decrease, and Olanzapine, a 12% decrease.
Haloperidol levels dropping by 70%. I mean, that means a smoker could be taking a dose that would be toxic for a non-smoker, yet they're receiving almost no therapeutic benefit. This is a massive failure point in treatment.
It is.
But here's the critical management alert. What happens when a long-term heavy smoker successfully quits smoking?
The reverse dynamic occurs, and it can be extremely dangerous. Smoking cessation removes the PAHs, and that enzyme induction is reversed. The liver returns to its normal metabolic rate.
Which means the drug is cleared much slower.
Much slower. So the drug plasma levels increase rapidly, often leading to toxicity or severe side effects, even at a stable previous dose. Clinicians have to anticipate this and plan for a dose reduction, often a substantial one, and close monitoring for up to a month after the patient stops smoking.
That is a life-saving piece of information. Now let's switch from speeding up metabolism induction to slowing it down, or inhibition, using the example of the antiplatelet agent clopidogrel and specific antidepressants.
Yes, this is a classic example of a drug interaction that leads to treatment failure. Clopidogrel, which is Plavix, is a prodrug. It's inactive when you first take it.
Okay.
To become the active antiplatelet agent that you need to prevent clotting, it must be metabolized by liver enzymes, primarily CYP2C19, 3A4, and 1A2.
So if an antidepressant inhibits or jams those specific activating enzymes, the patient is left completely unprotected from clotting.
Precisely. If the antidepressant inhibits CYP2C19, the clopidogrel cannot be converted into its effective form. This dramatically increases the patient's risk of dangerous clotting events, stroke, or a heart attack.
So what's the recommendation?
The strong clinical recommendation is to avoid fluoxetine, which
Yeah.
is a moderate CYP2C19 inhibitor, and fluvoxamine, which is a particularly strong CYP2C19 inhibitor, in any patient who relies on clopidogrel for their cardiac or vascular health.
Finally, we have to tackle the minefield of opioids and serotonergic agents. This involves not just dangerous side effects, but also that issue of efficacy loss we just talked about.
This combination is high risk across the board. First, the risk of serotonin syndrome is elevated, especially with opioids like tramadol, which itself has significant serotonergic effects. Serotonin syndrome is a possibility with any opioid, but the risk compounds exponentially when you combine it with two or more strong serotonergic agents.
Which includes most of our common antidepressants.
Yes, most SSRIs, SNRIs, the older TCAs, and even mood stabilizers like lithium.
Let's address that efficacy failure first. Why do some antidepressants cause patients to complain that their codeine or tramadol suddenly stopped working for their pain?
This is almost always due to CYP enzyme inhibition. Many common psychotropics are strong inhibitors of CYP2D6 and 3A4. These are the very enzymes necessary to metabolize prodrugs like codeine, oxycodone, and tramadol into their active pain-killing metabolites.
So if you introduce a strong inhibitor,
If you introduce a strong inhibitor, say bupropion, fluoxetine, paroxetine, or duloxetine, those are all strong CYP2D6 inhibitors, you block the activation pathway.
so you end up with high levels of the useless prodrug and low levels of the active pain reliever, resulting in treatment failure or even unexpected opioid withdrawal symptoms.
Exactly. The lack of active metabolite means the patient experiences a profound loss of analgesia. They're not getting their pain relief.
And then we have the compounding risk of central nervous system or CNS depression, which is particularly concerning when benzodiazepines or alcohol are in the mix.
That risk is so severe that combining opioids like methadone or oxycodone with other CNS depressants like benzodiazepines or alcohol is marked with an FDA black box warning. This combination significantly increases the risk of potentially fatal respiratory depression, coma, and death. Clinicians have to exhaust every other option before they co-prescribe these agents.
Methadone has a unique set of interactions that make it especially difficult to manage. What are the specifics with methadone?
Methadone is heavily reliant on CYP3A4 for its metabolism. Therefore, strong CYP3A4 inhibitors like fluvoxamine or high-dose fluoxetine can significantly increase methadone plasma levels, raising the risk of respiratory depression and other adverse effects.
And it has a cardiac risk, too.
It does. Methadone itself is a QTc prolonging agent, so combining it with our other high-risk psychotropics like citalopram, citalopram, haloperidol, or quetiapine dramatically increases the cardiac danger.
Given the danger of serotonin syndrome in these complex combinations, let's provide a clear, detailed overview of the symptom spectrum. What clinical features define serotonin syndrome?
Serotonin syndrome is typically characterized by a triad of symptoms: mental status changes, autonomic instability, and neuromuscular hyperactivity. It usually starts within hours of an overdose or a change in dose or medication.
And the mild symptoms are often missed, right?
Very often. They can be things like nervousness, insomnia, a fine tremor, nausea, and diarrhea, things you might attribute to something else.
So when should a patient or clinician recognize that the condition is progressing to a moderate level that requires urgent attention?
The moderate symptoms are defined by the neuromuscular signs, which are the most reliable indicators according to the Hunter serotonin toxicity criteria. These include hyperreflexia overactive reflexes, significant sweating, sustained ankle clonus, or inducible clonus.
Clonus.
It's a sudden, involuntary, rapid contraction of a muscle that you can provoke by tapping or movement. That, alongside agitation, is a key sign. The hyperreflexia and the clonus are the red flags that separate serotonin syndrome from other conditions like neuroleptic malignant syndrome.
And the life-threatening severe presentation.
Severe serotonin syndrome is marked by hyperthermia. The body temperature often exceeds 104 degrees F, sustained clonus and rigidity, profound confusion or delirium, and potential complications like rhabdomyolysis and severe metabolic derangement, all of which can lead to organ failure and death. Immediate discontinuation of the agents and supportive medical care is absolutely required.
Now we move into Section 5, exploring risks associated with substances that are often seen as safe or natural, and critical long-term effects of widely used prescription drugs that have only recently been conclusively proven.
We absolutely must begin with Kratom, or Mitragynous speciosa. This is an unregulated substance indigenous to Southeast Asia, often purchased legally in the U.S. as a powder or a capsule.
And people use it for what?
Users seek it out for its perceived stimulant effects, for pain relief, or for self-treating opioid withdrawal symptoms.
The lack of regulation alone is a huge risk. But what do our sources reveal about its actual pharmacological potency?
The pharmacological profile is highly concerning. Kratom contains two main active alkaloids, metraginin and its metabolite, 7-OH-metragine.
And that metabolite is the problem.
It's a huge problem. It's a powerful opioid receptor agonist, estimated to be 13 to 14 times more potent than morphine.
13 to 14 times more potent than morphine, available unregulated online.
Yes. And furthermore, Kratom also exhibits noradrenergic and serotonergic effects, meaning it acts as a weak SNRI itself. This is not a benign herbal supplement. It is a multi-system psychoactive drug.
Given the lack of controlled studies, what clinical adverse events are emerging, mostly through case reports?
The reports paint a very severe picture. They include acute symptoms like oversedation, weight loss, psychosis, extreme irritability, and increased aggression. The more serious events involve seizures, significant dependence and abuse potential, respiratory depression, especially when mixed with alcohol or benzos, and serious multi-organ system dysfunction, particularly hepatic toxicity.
And in the worst cases?
In tragic cases, coma and death have been reported. And given its opioid properties, if you stop it abruptly, it causes typical, sometimes severe opioid withdrawal symptoms.
And based on our earlier discussion about the liver, its metabolism means it's a powder keg for drug interactions.
Absolutely. Kratom's primarily metabolized by CYP3A4, 2D6, and 2C9. since it uses those critical metabolic pathways. If a patient is taking it alongside their prescribed psychotropics, especially SSRIs, SNRIs, or antipsychotics that also rely on 3A4 and 2D6, the potential for unanticipated toxicity or reduced efficacy is extremely high.
And patients might not even mention they're taking it.
Right. The clinical challenge is that patients often don't consider it a drug, and so they fail to disclose its use.
Let's move to a substance that every household considers safe, acetaminophen or Tylenol. The FDA took dramatic action concerning its safety limits about a decade ago. What was the central mechanism of danger that drove that intervention?
The central danger is cumulative, inadvertent overdose leading to hepatotoxicity or liver damage. Acetaminophen is safe within limits, but when the liver processes it, a small amount is converted into a highly toxic metabolite called NAPQI.
And the liver has a defense against that.
It does. The liver normally detoxifies NAPQI using a compound called glutathione. But if you take too much acetaminophen, exceeding that 4,000 milligram limit in 24 hours, you deplete your glutathione stores, and the NAPQI metabolite builds up and rapidly destroys liver cells.
And the specific risk the FDA identified in 2011 was related to prescription combination products.
Correct. Overdose from these combination products, acetaminophen mixed with opioids like hydrocodone or oxycodone, accounted for nearly half of all acetaminophen-related liver failure cases in the U.S.
Because people didn't realize they were double dosing.
Exactly. Patients often didn't realize that their prescribed painkiller contained acetaminophen, and then they would take over-the-counter Tylenol for a headache, easily exceeding the maximum daily limit.
So the FDA's solution was to cap the amount in those prescription pills.
Yes. They formally requested manufacturers of prescription combination products to limit the acetaminophen component to no more than 325 milligrams per tablet or capsule. This just makes it harder for a patient to inadvertently consume a dangerous dose. They also mandated updated warnings regarding the risk of severe liver injury on all products.
Is there an antidote?
There is. If a patient does overdose, the antidote is N-acetylcysteine, or NAC, which acts as a precursor to glutathione, helping the liver neutralize that toxic metabolite.
Finally, let's revisit the long-term cognitive shadow of benzodiazepines, or BZDs. These are ubiquitous for anxiety and insomnia, and while their acute risks, sedation, amnesia are well known, the persistence of cognitive impairment after chronic use was debated for decades.
It was a huge controversy. For long-term users, and the definitive studies looked at people using them for an average of nearly 10 years, tolerance usually develops to that acute sedation. But the crucial question was, are they causing subtle, potentially permanent brain changes? Earlier studies were just inconclusive.
What definitive finding emerged from the comprehensive meta-analyses that tried to settle this question once and for all? What was the aha moment for the clinical community?
The meta-analyses were conclusive and, frankly, sobering. They found significant, measurable cognitive decline in long-term BZD users compared to non-user controls across all 12 cognitive domains that they measured.
All 12. It wasn't just memory.
No, it was comprehensive. Specific domains impacted included visual-spatial ability, how you navigate space speed of processing, verbal learning and delayed recall, attention, vigilance, and psychomotor speed. Long-term use impairs cognition across the board.
That's a powerful indictment of chronic use. But what happens when the medication is stopped? Is the damage reversible?
This is the critical and perhaps non-reversible finding. After BZD withdrawal, patients did show measurable improvement in cognitive function, and some of the acute symptoms resolved. However, they consistently fail to return to the performance level of the benzodiazepine-free control groups.
That's a game changer. It implies either a permanent neurocognitive deficit or deficits that take far, far longer than the several months they often track in follow-up studies to fully resolve.
That's the implication.
So what does this mandate for clinical practice?
It mandates full transparency. Clinicians should now advise patients of this potential for long-term or permanent cognitive change prior to initiating treatment, especially if the use is anticipated to be long-term. Even if the effect is subtle in a low-demand environment, the objective deficit is undeniable when you compare them to controls. This shifts the risk-benefit discussion dramatically for chronic anxiety management.
This entire deep dive has been rooted in the complexity of risk. Let's finish by looking at the practical strategies for managing these high-stakes medications when the patient themselves presents with compromised organ function, meaning their liver or their kidneys are not working at full capacity.
This section really represents the ultimate test of pharmacological knowledge, because if the primary clearance route for a drug is compromised, the therapeutic window shrinks dramatically and toxicity becomes a major risk. We have to adjust dosages to prevent catastrophic accumulation.
Okay, starting with liver impairment and psychotropics. Which agents carry the highest intrinsic risk of hepatotoxicity and therefore require the most caution?
While severe hepatotoxicity is rare, we're talking 0.001 to 0.1%, the risk is known to be higher with valproic acid, which carries an explicit black box warning for hepatic failure, carbamazepine, and duloxetine, which can cause transient ALT elevations in about 1% of patients.
So if a patient presents with known liver dysfunction, which common psychotropics must be completely avoided and which need aggressive dose adjustments?
The rules are very strict. Duloxetine, because of its known risk for ALT elevation and its dependence on liver metabolism, must be avoided entirely in severe hepatic impairment.
Okay, that one's off the table.
Citalopram's maximum dose drops immediately to 20 milligrams per day. And venlafaxine, which is also heavily metabolized by the liver, requires its dose to be decreased by at least 50% in patients with moderate to severe hepatic impairment.
Are there any mood stabilizers or common treatments for alcohol use disorder, AUD, that are actually preferred in patients with liver failure?
Yes, there are exceptions based on their clearance pathways. Lithium requires no dose adjustment for liver impairment because it is cleared 100% by the kidneys. It completely circumvents the hepatic system.
So it's a safer choice in isolated liver failure.
It is. And for AUD treatment, while naltrexone is effective, it should be avoided if the baseline liver function tests, or LFTs, are more than 5 times the upper limit of normal. The superior agent for AUD treatment in a patient with hepatic impairment is acamprosate.
Why acamprosate?
Because it requires no dose adjustment. It's also cleared non-hepatically, primarily via the kidneys, and it has not been associated with liver toxicity.
That's a clean transition to our final organ system, the kidneys, or renal impairment. You just mentioned lithium's safety in liver failure is offset by its notorious risk to the kidneys.
That's the classic trade-off in pharmacology. The kidneys are absolutely critical for clearance, and any failure necessitates adjustments based on the estimated clearance rate, or GFR. Lithium is infamous for its renal toxicity, including interstitial nephritis and nephrogenic diabetes insipidus. And because its therapeutic window is so narrow, dose adjustments are non-negotiable.
So what are the specific dosing limitations for lithium based on kidney function?
If a patient's GFR is moderately impaired, that's between 30 and 89 millim in lithium, lithium must be started at a very low dose and titrated very slowly and cautiously, with continuous monitoring of their levels.
Man, if it's worse than that.
If the GFR drops below 30 millim, the drug should be avoided entirely due to the extreme risk of severe, irreversible toxicity and eventual kidney failure.
And what other common psychotropics require absolute avoidance in severe renal impairment?
Similar to the liver, kidney failure dictates absolute avoidance of several agents. Duloxetine is a dual threat. It must be avoided if CRCL is less than 30 millim. Venlafaxine's immediate release formulation requires a 25% dose reduction if GFR is between 10 and 70 millim, with even deeper cuts required for the extended release version or if the patient is on hemodialysis. The kidneys are often the limiting factor for safe psychiatric medication use.
Finally, let's discuss the critical metabolic risks associated with the second-generation antipsychotics, or SGAs. These are lifelines for many patients, but they carry a serious systemic risk known as metabolic syndrome.
This is a major public health concern. The SGAs dramatically increase the risk for metabolic syndrome, which is not just a diagnosis of weight gain, but a clustering of risk factors.
How is it diagnosed?
Metabolic syndrome is diagnosed when a patient meets 3 of 5 specific criteria: elevated waist circumference, elevated fasting glucose, elevated blood pressure, elevated triglycerides, and low HDL, or good cholesterol.
And which specific antipsychotics are the biggest culprits in driving these metabolic changes?
The highest risk drugs, by far, are Olanzapine and Clozapine. They carry the highest comparative risk for weight gain, glucose dysregulation, and increases in triglycerides. They're often noted as a 4+ risk in comparative safety tables.
And others?
Drugs like risperidone and quetiapine carry an intermediate risk, while aripiprazole carries a much lower risk.
So how does this high metabolic risk translate into required clinical management? It must involve intensive monitoring to mitigate the chance of future diabetes or heart disease.
It absolutely requires intensive, non-negotiable monitoring. Weight, blood pressure, fasting glucose, and lipid panels must be checked at baseline before treatment even begins.
And after that?
Then the monitoring has to be frequent. At weeks 4, 8, and 12 of treatment initiation or any dose change, and then annually thereafter for life.
If the patient's lifestyle modifications, diet, and exercise, if they fail to control these parameters after those first 3 months, What's the pharmaceutical fallback?
The most studied adjunctive therapy to address SGA-induced metabolic risk is metformin. While metformin is primarily known as a type 2 diabetes treatment, it's used here to help stabilize or slow down the weight gain and glucose dysregulation, particularly in patients on high-risk SGAs like Olanzapine and Clozapine.
Does it work well?
Well, it rarely results in major weight loss, usually only about 10 to 15 pounds, but its utility is in stabilizing the metabolic parameters and preventing further decline.
This has been a truly comprehensive exploration. We've moved from the macro-level paradox of public health warnings leading to unintended suicide attempts down to the microscopic level of CYP enzyme induction caused by tobacco smoke and the subsequent need for rigorous organ-specific dosing adjustments.
It has.
The common thread here isn't just about the drug's intended action, but about its systemic compatibility with the individual patient.
That is the ultimate synthesis. The most effective therapeutic strategy consistently involves nuanced decision-making. Choosing an SSRI for excellent tolerability, but switching to an SNRI if chronic pain is present, or selecting an antipsychotic based on its metabolic profile, like choosing aripiprazole over olanzapine for a patient already struggling with high cholesterol.
But above all, it's about the dose.
Above all, effectiveness and safety hinge on meticulous attention to dosage, avoiding high-dose venlafaxine in hypertensive patients, or capping citalopram to prevent QTc prolongation.
And we highlighted the incredibly complex interactions between psychotropics and common substances like smoking, where the tobacco smoke drastically reduced drug levels. We saw that haloperidol levels, for instance, could plummet by up to 70% in heavy smokers.
That 70% drop is perhaps the most profound lesson we discussed today. When you're assessing a patient's actual response to treatment, particularly if they seem treatment-resistant, there is one essential non-pharmacological element that you must always consider when assessing their true drug adherence, far beyond just counting the pills in their possession. What is that essential factor?
Their smoking status. Because you can have the most perfectly chosen, appropriately dosed medication, but if the patient is inducing their own metabolism via combustion products like tobacco smoke, they may be destroying up to 2/3 of the drug before it can ever reach its intended target. That is the critical variable that sits outside the pill bottle, and it is something for you to mull over the next time you or someone you know considers taking any long-term medication.